Good afternoon. This is Dr. Bill Campagna, and this is Relationship Matters. Welcome, and thanks for joining us. Denise Evans, my co-host, is taking a long-deserved vacation, and we wish her well wherever she is, hiding out in the Eastern Hemisphere of the United States. She didn't exactly tell me where she was going for various reasons, but nonetheless, I do wish her well, and hopefully she'll be back with us, I think, in 2 weeks. In any case, we'll do our best to hold the fort without her today. Our guest today is Dr. Anthony Todaro, who's a clinical psychologist who practices in Hampton, New Jersey. He's been a psychologist for over 40 years, and he's a specialist in marital family counseling. And he has a specialty that I think is just so interesting and perhaps very relevant to a lot of our listeners, which is helping individuals who have been traumatized psychologically in one way or another, helping them both individually and also helping their families. So our topic today, which was actually suggested by Tony, is psychological trauma, the silent killer, which sounds ominous, and hopefully he'll explain it a little bit more to us. Welcome, Tony. Thanks for coming.
Thanks a lot, Bill. The silent killer came to me because my friends who are physicians are always talking about high blood pressure, which I have borderline high blood pressure, and hypertension as the silent killer. Strokes, heart attacks, kidney disease, all kinds of problems ultimately arise from hypertension, and we have very adequate treatment for it at this point in time. However, psychological trauma is not something that's easily seen or discussed in either the psychological or medical communities. It's a killer, but it's quiet. No one knows about it. But people see the results, and the results are devastating. The results have uprooted marriages, families, destroyed the psyches of children, have created underachievement in school, have caused people to develop very severe phobias, very severe compulsions, and all kinds of unexpected depressions which are of unknown origin. So today maybe we can examine some of the excitement, interest that people do have in trauma.
Well, you know, we are using a term that I think people hear a lot. They hear the word trauma, and that fits into various other diagnoses and stuff. What exactly, in your opinion, is a trauma, and how can it affect people?
Well, there are two types of traumas if we break it down into its simplistic form. The first is usually a physical injury or wound, usually imposed by an external force or some kind of violence, such as either homicide or suicide. And this is actually the principal cause of death between most people between the ages of 1 to 38 years. And the people who are affected by traumas, two of them out of the, as opposed to one who will die, will be disabled for life. Unfortunately, psychic trauma is one which is not seen as easily, and that's usually an emotional or psychological shock, a real serious shock. And it produces all kinds of disordered feelings or behaviors that we're not too happy with afterwards.
So in other words, a trauma then is a blow or a shock. It could be physical, as in a physical injury, or it could be emotional or psychological.
That's correct.
Okay.
And working with a physiatrist for 5 years of my many years in practice, a physiatrist is a specialist, a medical specialist in physical rehabilitation. We treated many hundreds of people who've been in automobile accidents, airplane accidents, fall-down accidents, and these were physical traumas which led to very serious psychological traumas, because the psychological trauma then becomes very apparent when you can't earn a living, any longer. You cannot go to work and support your family. You begin to find that the people around you do not see you as a productive person and begin to reject having you about. There's a despondency that goes with trauma because then it debilitates you in many ways. And because you can't earn a living any longer, it destroys your entire life. Sometimes the physiologic parts, such as your eyesight or your hearing, may go, and that takes away another piece of joy that you may experience in daily living.
Are you suggesting then that a psychological trauma, a non-physical insult to the body, obviously then can affect the body even though there's no direct injury?
Oh, it affects the body very deeply. I know, Bill, you don't like me to use too many those fancy neuropsychological terms.
Not too many.
Not too many. Okay. But anyway, we know, and I'm going to make the physiologic part very brief, that the hypothalamus, a little gland that's way down deep in the brain, one that we have no direct control over, and all of us believe we should be able to control all our behaviors because we're responsible people. But this hypothalamus does all kinds of funny things to us. It controls our breathing. It controls our heart rate. It controls how much we eat. So eating disorders can result from hypothalamic disturbance. It controls, again, how often our intestines work. Peristaltic action. It causes diarrhea. It causes constipation. Causes sleep disturbances. So the hypothalamus is a very potent gland, very, very strong. And we will get into the hypothalamus a little bit later because it affects our lives totally.
Okay, so on that, we'll take a quick break and be back and talk more about trauma with Tony Todaro. We're back. This is Dr. Bill Campagna on Relationship Matters. Our guest today is psychologist Dr. Anthony Todaro, a family psychologist who practices in Hampton, New Jersey, and specializes in marital and family therapy and also helping individuals who've experienced trauma. Before the break, Tony, we were talking about how the brain contributes to the overall experience of a person. One thing that struck me, though, just to, if I could digress for a second, is I'm always fascinated by how movies and television, particularly movies lately, have kind of promoted movies that have a trauma in them. I think before the show we were chatting about Titanic.
Yes, Titanic was a major trauma, which had its, I believe, I had seen 2 Titanics prior to this one, and of course they're all about trauma. There is somewhat of a love story in it, too, which makes it perhaps a little bit more interesting.
Of course.
However, the excitement of the trauma, particularly when you can watch it from a distance, is almost like a vicarious distancing from something that's really potentially threatening to all of us as human beings. There are many, many movies that deal with the natural phenomenon type of traumas, like Backdraft, Twister, Dante's Inferno, and I think San Elmo's Fire. There's a whole bunch of movies where you see traumas that are terrifying, and yet they excite us at the same time, get our adrenaline flowing. And, of course, people are curious about traumas and also involved with them consistently. We do like war movies. They're very popular. And people watch wars. They watch people getting shot. They watch people getting destroyed, maimed, hurt. And people are also very curious about things such as murders, rapes, violence. These are all traumas to the people who are involved. And yet, we take it for granted that those are the type of movies we have. And yet there's a very natural curiosity because we all worry at some level that a trauma could potentially occur to any one of us. It's easier to observe it in the movies since it's not out of your control, where it is out of your control
Now
when it
that
happens to you.
I'm going to guess that that's going to be a very significant factor in a psychological trauma, the lack of control or the perceived lack of control.
That's correct. That is probably the benchmark for real psychological trauma. You do not have control over what is happening, and particularly executives who do not have control over things that are traumatizing to them are the most traumatized people around. It was almost like the trauma inflicted by the executive monkey to his companion, where he would have control of the shock. Mm-hmm. And the other poor guy just got completely debilitated from the constant traumas, where the one who had some control at least was able to stay on top of it. The other one who was getting the shock and couldn't do anything about it internalized all the anxiety and became a complete passive, depressive monkey.
And I would guess also that in treating individuals who've had, whether it's psychological trauma or physical trauma, in dealing with the aftermaths, whatever they may be, I would imagine that helping them feel that they're regaining control is a very important part of the treatment.
Absolutely. Regaining control is essential to any kind of treatment, and understanding the dynamics of what's happening to you is one way of getting control. Learning relaxation techniques is another way of getting control. Being able to find support groups is another way to regain control. To see that there are other people who suffer with the same kinds of disorders you do is definitely always a method of controlling your life. Going for different kinds of therapy is another way to gain control. Some people prefer methods such as Tai Chi or meditation or yoga. These are all forms of developing relaxation techniques for the purpose of getting control over what has happened to you. The real threats of trauma are usually the element of surprise. Unexpected news is a big threat. And unexpected news is something that usually takes us by surprise, gets our neurotransmitters going at high pitch, sending electrical impulses throughout your whole body, and actually potentially making you sick. So the beginning of getting this kind of news will develop what we call the hypothalamus losing a certain amount of what serotonin, which is the neurotransmitter that keeps it healthy and happy and keeps you healthy and happy, and then suddenly throwing a lot more adrenaline into your system. That adrenaline, which we all know, can give us a surge when we're ready to fight or ready to run. Fight or flight is an extraordinarily powerful hormone. Part of that hormone gives us a great deal of energy. A surge of blood sugar makes us strong, can make us run, fight, do things that we didn't expect to do. But the other part of it is what we call cortisol, or which you commonly known as cortisone, and that's the part that actually causes the reduction of inflammation in your body. Now, your body, as it's getting depleted of cortisol, begins to become ill because it can't take care of all the inflammations and pains and unhappinesses that go on within the whole body. And as a result of repeated imagining of trauma, we lose a great deal of this hormone, and ultimately we become sick.
That's fascinating. Now, maybe it would be helpful just to talk a little bit about what kinds of events might be termed a trauma. I would think that many people in the world, I'm sure many of our listeners, have had traumas, but obviously haven't been on the Titanic or haven't seen someone murdered in front of them, or perhaps haven't gotten catastrophic news or haven't been in a war. Still, obviously, they would be vulnerable to trauma. What sorts of traumas might affect people that might be less dramatic, but nonetheless powerful and potent in affecting people?
Well, I have several patients who've experienced traumas which may not seem like traumas to some people. But, for example, going back to the constipation diarrhea, one person developed from an early life trauma. He's an executive, and he developed what's called irritable bowel syndrome. That means that he has an intestine that really makes him go at any time, and he has no control over it. Now, unfortunately, what this did was, because he had to run meetings and had to be in interviews such as you are and the type that you conduct as the host of the show, he would become very panicky when he would go to these interviews, because his biggest fear was that he would have to run up and go to the bathroom.
Lack of control.
Lack of control, exactly. So he would begin to check out every bathroom in the place and try to locate himself as closely as possible so he'd be able to escape at any time. Now, another type of trauma, which is not an active trauma, but one which people experience as very intense anxiety, is going in an airplane. Now, I'm a pilot, and used to have a fear of flying school. And we used to teach people how to try to overcome the trauma of flying. Flying's very scary for some people, and they have all kinds of they imagine vividly all kinds of things that could happen to them. But as we begin to reduce it down, once they understand the mechanics of flying, and we realize that the mechanics are much safer than that of driving, the real fear underlying this is what we call claustrophobia. Claustrophobia is a phobia where you're afraid of being in very tight places. And all of my aviophobic patients, interestingly, were claustrophobic. To my surprise, this is something I discovered over many years. And they were actually afraid of being in a very tight place without the ability to escape. And this is what happens to people who have to fly and feel they're in a claustrophobic situation, and the anxiety increases phenomenally. They begin to sweat, they begin to breathe shortly, they hyperventilate, and before you know, they could have an actual panic attack. Now, this is what traumas lead to. Traumas do lead to panic attacks. And panic attacks come in a variety of levels.
Now, a panic attack isn't just having anxiety, right?
No.
Okay.
It's having very intense anxiety. It's at the level 5 panic attack is a real danger. It's a danger zone panic attack. Person is breathing very rapidly, shallow type of breathing. They're shaking. They are. They cannot wait to leave the situation they're in. They're feeling they're going crazy. They see it that way. It's a terrifying experience, and anyone who's experienced a panic attack will realize that it's extraordinarily debilitating, and is one of the disorders that's a decompensation of post-traumatic stress disorder, which we will define in more detail.
Now, perhaps after the news, we can talk a little bit more about that term you use, post-traumatic stress disorder. A lot of people hear about this. It's on the news. It's on many talk shows, and hopefully we can talk a little bit more about that. But staying on the topic of anxiety just for a second.
Yes.
When an individual has suffered a trauma, do they know they've suffered a trauma? Can an individual suffer what you would term a trauma, but not be aware of not of its effects, because obviously that's going to be in the aftermath, but is it possible that an individual could experience a trauma without knowing that they've experienced a trauma?
Yes. When we're traumatized, for example, let's just take a simple trauma. Let's say you fall down and hit your knee real badly, and you get up and you feel okay, and you walk around as if nothing happened, and then 2 days later you suddenly feel a terrible pain in your knee, and you say, oh my God, what happened? And what happened was that another part of the brain, called the opiate center because it happens to like opium.
Okay.
And that center of the brain, again, which is not in our control, actually creates little chemicals called endorphins.
Mm-hmm.
And these endorphins actually act like opium or codeine, like Percocets, which people have taken for pain, or morphine, which people have taken for pain, or heroin, which many people have taken for pain. And they have usually very little recollection of how come this happened to me. And then they realize eventually that, well, this was something that I got hurt with. I fell down. I'll tell you about a personal trauma with a patient of mine, a little boy, many years ago when I was a child psychologist, and he thought I was Thrush, one of the shows that were on where I was one of the monsters, and he punched me real hard in the chest, and I didn't want to feel like I was a bad therapist, so I just restrained him, and then approximately 2 weeks later, I thought I had a heart attack. Went to my physician. He said, oh, no, your cartilage is broken in your chest. Well, I had repressed the whole incident, and only one of my colleagues happened to remember what happened and told me about the pain and the fact that I had pushed the pain out of my mind and did not want to deal with being so angry at a patient.
That's fascinating. That's certainly something that we want to touch on when we come back after the news. We'll be back in a few minutes. Welcome back to Relationship Matters. This is Dr. Bill Campagna. Denise Evans is on vacation. And our guest today is Dr. Anthony Todaro, a clinical psychologist who practices in Hampton, New Jersey, who's a specialist in family therapy and who has a specialty also in helping individuals who have suffered trauma. And our topic today is how people who have suffered trauma can heal and move on. Before the break, we were talking about how individuals who are traumatized exhibit oftentimes very similar symptoms. And one of the things we talked about something called post-traumatic stress disorder, or in short, PTSD. Tony, exactly what is that?
Okay, Bill. First, I think we need just a little tidbit of history to get a background on what PTSD really is. During the Civil War, after the Civil War, I should say, soldiers who came back would have very rapid heartbeats, and there was an old doc by the name of DaCosta, and he said that this was an irritable heart type of problem. So he used to call it the irritable heart of soldiers. And that's how he described what happened to soldiers after a war. Then after World War I, they took away that term, but they did use officer's heart or officer's neuroses, or some people would call it shell shock, and some even called it neurasthenia. These were all names that were given to people who had served in service and were having all kinds of symptoms that docs didn't understand in those days. World War II, they were also concerned with what we called war neuroses and conversion hysteria, which meant that soldiers were getting paralyzed and there was nothing wrong with them, and they were getting blind and there was nothing wrong with their eyes. They would have all kinds of anxiety states, and they would call it physioneuroses. And again, we opened up many VA hospitals after World War II, And that's how psychologists came into practice.
That's true.
And that's why we're here today, because of World War II and the fact that treatment for soldiers was taken very seriously. And our veterans who had served the country had put in a great deal of effort and needed a great deal of treatment.
So at the time then, physicians treating veterans picked up that something was wrong, and oftentimes it had a physical component to it.
Yes.
But it sounds like they weren't quite on target as to the full range of the incidents that had precipitated it. They were focusing more on physical causes specifically?
Yes, mostly physical, but they realized something was happening that was beyond the physical, and they had some psychiatrists, some MDs who specialized in understanding human behavior, but they didn't have enough, and psychologists were trained specifically to understand human behavior, and they were beginning to do a great deal of the research and testing and diagnosis of these soldiers. So these combat neuroses, which were pretty prevalent after World War II, actually there were 918,961 admissions to the VA hospitals for neuropsychiatric problems.
Wow.
That's 1 million people, just about. Very close. That's a lot of people. And so you could see how they were suffering rather severely. Okay. Then what happened was the soldiers were again suffering, particularly after the Korean War, but not a whole huge amount of work was being done until Vietnam. Vietnam seemed to be the main trigger for the development of the term post-traumatic stress disorder. The term actually came into existence in 1980, so it's a relatively new term. And it's a relatively new disorder. And we realize it doesn't only apply to soldiers, although soldiers generally had a much more intense negative experience and an accrual of negative experiences, as you, I think, said, Bill. You said it's like notches in a gun, keeps on piling up, and you know that things are really hitting you pretty hard. You see a lot of people maimed, a lot of people injured.
It's also a very interesting sort of example of how science, psychology included, develops. The disorder itself, the name that we've given it, post-traumatic stress disorder, is new, but the disorder itself is not new. It's just that we, as time goes by, are able to clarify it and amass more experience.
That's correct, and redefine it and amplify on it and begin to understand it and know what to do about it a little bit better. The diagnosis came out in one of our diagnostic and statistical manuals back in the 1980s, called DSM-3R back then. And I'll read you some of the definitions. We'll try to make them interesting, though, and make them a little bit more lively. Usually, the criteria is a person would have experienced or witnessed or was confronted with an event or events that involved actual or threatened death or serious injury or threat to physical integrity of self or others. I just had an example yesterday, which I thought was interesting of this. This is a woman I've seen for approximately 20 years who suffers from what we call chronic agoraphobia.
Which is?
Agoraphobia is afraid of leaving. That person is afraid to leave the house, who has to go through very, very strong rituals as to how to drive around. They need company to go to any new place. They're terrified when they leave their home. And she's so terrified that even if she goes next door to her beautician, she will want to be sure the door is open and want to be able to run back home. One day I even took her to a restaurant to desensitize her, and she insisted on sitting right by the door and kept on looking at that door to be sure it was open and close to her.
To keep control, basically.
Exactly. Right? And we could never totally overcome the disability, and she still lives with it, but at least we control it now through relaxation and the use of an anxiolytic, a tranquilizer called Ativan, and she takes it sublingually. My shrink many years ago taught me that trick. You put it under your tongue, and it works like nitroglycerin for people with anxiety. So as soon as they feel some anxiety, they put it under their tongue, and then they feel completely relaxed. It goes right to the brain within 4 to 5 minutes, and relaxation takes place. And so it's a pretty effective form of treatment. However, learning self-relaxation techniques and hypnotherapy techniques are very helpful as well. The way she developed her agoraphobia was she got a panic attack, particularly when she saw her son racing his cars right here near Flemington. And he used to speed around, and he crashed a couple of times, and the car caught fire, and she was afraid he was going to die. And he didn't die, but she was so traumatized that she never wanted to drive again. So she was afraid to drive, and then she was afraid to leave her house, and before you knew, the panic became so severe that she couldn't go to work anymore. And so now she's still out on disability and very concerned about her 2 children, because she tells me they also have agoraphobia, as she confessed to me the other day. This was a major confession, and we may feel or draw some conclusion that perhaps this is something genetic as well. Maybe we're genetically predisposed to having these kind of problems, and if the environment gives us the opportunity to have them, then we have them. So witnessing the threatened death of a son was enough to meet the criteria of a post-traumatic stress disorder. And the person's response, which is the other criteria, is it involves intense fear, helplessness, or horror. Well, if you see your kid racing around, crashing into a wall, his car catching fire, you feel helpless, you feel horrified, you feel fearful of everything of what this describes. So she meets that part of the criteria. Now, the second part, and Bill, I'm sure you're very well aware of these, are the recurrent and intrusive, distressing recollections of the event, including images, thoughts, or perceptions. And we know there are 2 parts in the brain, which I'm not going to go into because I know you don't want me to be over physiological. So, but there are 2 little parts in the brain that we don't control, and they're stimulated constantly by little neurotransmitters, and they keep us hopping, and they keep those images alive and real, and they make us feel that way all the time. And it's a very, very disturbing feeling.
So in other words, after the individual has experienced the event, whatever it may be.
Exactly.
It's not over.
It's not over.
Even though it's over temporally, it's no longer actually occurring.
That's correct.
The body, and perhaps the brain, but certainly the person, which is a combination of those 2, is still, in a sense, experiencing the aftershock of the initial event.
That's perfect. Aftershock is the correct word. And there have been several books written on aftershock, and I believe you know one of the authors. You had worked with him many years ago.
Yes.
And what's his name? Andrew?
Dr. Andrew Slaby.
Slaby.
Right.
Okay.
Right.
And he wrote a book on that, and it's very descriptive of this kind of problem. The second are recurrent distressing dreams of the event. Now, dreams are very important, and the thing to note is that post-traumatic stress disorder causes disturbance in REM sleep. Most people who suffer from traumas and live with the aftershock develop a chronic sleep disorder, and the chronic sleep disorder makes them jump up in the middle of the night or can't fall asleep, develop insomnia. Or if they do have a dream, it's a terrible dream. They may be afraid to dream, so they rather not go to sleep.
Mm-hmm.
Dream analysis is very fascinating, very interesting. Myself as a patient with one of my analysts, a favorite professor of mine, we spent 4 years in dream analysis. And we went into all the dynamics of dreams. It's really a very exciting adventure. Well, in this group that I'm reading right now are two.
Right.
So if you have two of these symptoms, you're essentially, by definition, have met the criteria.
Okay, good. We'll be back in 1 second. Welcome back to Relationship Matters. This is Dr. Bill Campagna. Denise Evans is on vacation. Our guest today is Hampton, New Jersey psychologist, Dr. Anthony Todaro, a specialist in marital and family psychology who treats many individuals who have been traumatized. We're talking about something that has received a great deal of press on the past few years, PTSD, post-traumatic stress disorder, and we're talking a little bit about some of the criteria that psychologists use to make the diagnosis, right?
That's correct. Well, Bill has a lot of expertise in this area too, so he's a great listener. A great interviewer.
Hey, listen, come back anytime.
Okay, we're up to number 4, where you have intense psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of traumatic event. Okay, what does that translate to? It translates that if you were in a car accident and you had a crash, and you see the possibility of an impending crash at a specific area, you might suddenly jump or lurch or become very, very upset at the possibility of having another crash, and you just don't want to have that happen to you. Some people call those people backseat drivers, but they may be suffering with one of the PTSD symptoms. Also, physiologic reactivity on exposure to internal or external cues that resemble an aspect of traumatic event. The person passing a place where they had the accident, for example, could relive the incident by beginning to perspire. Their heart may start racing. Their breathing may become shallow. It may be a very uncomfortable experience. Now we're going to go into the parts of the avoidance aspect which have a great deal of impact on family. Family is very much affected by PTSD, and that's why I call it the silent killer. So the rest of the symptoms, which I'm going to discuss with Bill, have to do with the fact that these are the symptoms that ultimately destroy families. This is a contagious issue. It is not something that is non-contagious. PTSD and the ramifications of it are contagious within all family structures, and that's why we have such a high divorce rate in this country, I believe, which is now at about 55% and rising.
There are, of course, other dynamics also. I think it's important to point out that while individuals sometimes aren't always cognizant of the traumas they have suffered, not everyone who perhaps has a dysfunctional marriage or a marriage that doesn't work out necessarily could state that they've been traumatized, or that trauma is automatically to be considered the core of that particular problem. It's something that affects many people, many more people than we actually ever thought, but certainly not everyone has been traumatized, correct?
Well, it depends. If you weren't a C-section baby, Phyllis Greenacre many years ago, an old psychoanalyst, said that we all go through a birth trauma. And she says that's our first introduction to life is through trauma. So that's, of course, perhaps an archaic joke in our field, but it may have some relevance.
Perhaps. So then actually, the experience of trauma obviously is something that we've all experienced. However, not all of us have experienced, have we not, life-threatening traumas? For example, one of the examples you gave was of a lady who had seen her son almost killed in a race car accident.
That's correct.
But there are individuals who can be traumatized and meet the criteria for a post-traumatic stress disorder who haven't experienced such dramatic events. It's not the event, it's how the event is perceived, right?
That's correct.
Okay, because I think for our listeners, many people would say, well, I haven't been in a war, I haven't been in a car accident, I haven't seen anything horrible. But it's not the objective event, it's how the individual perceives the event.
That's absolutely accurate.
That's an important factor.
Perception is the most important thing within human beings. Okay, it says here, efforts to avoid thoughts, feelings, or conversations associated with the trauma. Now, what happens at home is the person who feels that way doesn't want to begin not to want to talk. Mm-hmm. Efforts to avoid activities, places, or people that arouse recollections of the trauma. What happens is then the person who's suffering with this doesn't want to go anywhere. They rather stay home. They rather not talk to their friends who used to be friends. They start withdrawing. They lose interest or participation in significant activities. They feel detached or estranged from others and lose the sense of being affectionate. They're not able to have the same range of love feelings, so they may reject their children. They may not want to be with their wives or husbands. They have a sense of a foreshortened future. They don't expect to have a career, a marriage, children, normal lifespan. They figure they're going to die young. It's very scary. And these particular manifestations of behavior become very, very upsetting to a mate and to the kids. And they absolutely destroy the family. Okay, as a final, the things that happen also at home are difficulty falling or staying asleep, which we said and talked about, irritability or outbursts of anger, which is the biggest problem because PTSD people become very abusive parents and are screaming all the time. If they're kids, they could be very difficult kids and do all kinds of delinquent things that upset people. Difficulty concentrating, so they can't work as well or go to school as well. Hypervigilance, which means they're always looking around, always being extra cautious, extra worried about what's going to happen to them. And they have an exaggerated startle response. So if they hear a noise or something, they may jump a little bit more and be more jumpy than somebody else. These are the criteria for PTSD. And I think we should be aware of the fact that there are other types of shock that we've all encountered, and I believe Bill mentioned the idea of divorce as a form of a trauma. Well, divorce is traumatic to many people.
I think that also it's helpful for people to understand that they may read an article or perhaps are listening today as you kind of talked about the official diagnostic criteria for a particular disorder, in this case post-traumatic stress disorder, that it's not important, in my opinion, that an individual, well, I've got only 4 out of the 5. Well, those 4 are problematic. It's not a question of do I or don't I have this particular disorder, but rather, do I have certain problematic dynamics of the disorder that I need to work on? It's not, this is my disorder, this isn't my disorder, but rather, what dynamics does an individual have in his or her life that might be problematic for them? Would you agree?
Yes, great. Absolutely.
When we come back after the break, maybe we could talk a little bit about treatment, how psychologists and therapists can help people who have experienced trauma and to help them gain control and perhaps move on with their lives. We'll be back in a few minutes. Welcome back to Relationship Matters. This is Dr. Bill Campagna. Our guest today is psychologist Dr. Anthony Todaro, who's a family psychologist who specializes in treating individuals who have experienced psychological and sometimes even physical trauma. Before the break, we were talking about how trauma, and specifically post-traumatic stress disorder, the particular disorder, affects families. And maybe it would be a good time to touch a little bit on treatment. How do you help people? What issues do you look at in helping an individual who has either suffered a trauma or perhaps even has many or even almost all of the diagnostic symptoms of a post-traumatic stress disorder?
Well, first, just like in allergies that people have developed, whether it's to foods or to pollens or to bees or to antibiotics like penicillin, after people keep on getting exposed and if their body doesn't respond well to these allergens, eventually they go into shock and they can die from it. It's called anaphylactic shock, and then they need a shot of adrenaline to keep themselves going. And people who are very allergic to these things, for example, go around with a little kit, and that's their treatment kit, just in the event they're attacked and they're traumatized and their body can't handle it. It's a very frightening experience, but it's physical in nature, but again, a psychologically disturbing experience. What we do in treating people with trauma is first to help them identify what the trauma is and whether or not it actually existed. Most people are not aware of that. They may come in for eating disorders, for example, for bulimia, and then we found out that either their grandmother died from cancer and lost a great deal of weight, and that was very frightening, or they may have someone in the family who molested them, and therefore they thought they were sexually over-attractive and they want to make themselves unattractive. These are some of the reasons why someone would develop a condition called bulimia. Now, the bulimia, the eating and throwing up, or eating and not throwing up, depending which type it is, or using laxatives, or becoming anorexic, which are very common eating disorders, are very often there is an underlying trauma. The person's not aware of the trauma. They're only aware of the fact that they're eating in a way that doesn't make them happy, and they're either too fat or too thin and uncomfortable with the pattern.
Now, when you say the individual's not aware of the trauma, are you suggesting that if you said to the person, this happened to you, they'd say, no, it didn't? Or are you suggesting that they might be aware that it occurred, but not aware of the impact that it had on them?
Exactly. The second is correct. They're aware it occurred, but not aware of the impact, is the exact occurrence within the person. And the way we try to treat that, we teach people how to use hypnosis, which is a form of relaxation therapy, or meditation if they're more comfortable with that. And we use what we call age regression. Age regression is we let people go back to a time in their lives with their eyes closed so they're not too concerned about their doctor. They're more concerned about their experiences. And they go back into time and they're able to talk and feel and think the way they did then. And they can discover for themselves many, many fascinating things that have disturbed them. Normally, age regression is a very interesting tool, and it's an exciting adventure for both therapist and patient, and we can come up with some very interesting findings. In my case, I still use the headphones that I had from my airplane when I would take people flying, and we are in a very private setting, and they can actually relax, listen to the ocean, and just feel absolutely comfortable. That's a wonderful way to get to certain traumas and to undo them. To kind of call, the old term was abreaction, to be able to get all the feelings out and perhaps eliminate some of them.
So in that particular aspect of treatment, and as we both know, treatment is very complex, but in that particular component of treatment, you would assist the patient in recalling the event itself?
Yes.
While they're relaxed.
If they just choose to go to that time in their lives, they may be, the event may be so painful that they won't go to that area until they're much more comfortable with the therapist. The next type, the approach for treatments will depend on what a person's presenting symptoms are. People do not come in presenting PTSD, post-traumatic stress disorder. They come in, for example, with major depression. Major depression is always a result of PTSD, not always, but often. Usually some trauma causes a decompensation within the hypothalamic area, that you remember that little gland we talked about early, and that takes away a lot of serotonin. And so what we try to do initially is to implement psychopharmaceuticals. We use either their family physician, their internist, their psychiatrist, whoever it happens to be, who's willing to utilize some of the newer antidepressants, which are called selective serotonin reuptake inhibitors. What they do is they actually pump in a lot of that nice neurotransmitter that we used to get from turkey and milk called serotonin. Again, tryptophan is what you really get from those. It's an amino acid, but it gets converted to serotonin, and we need more serotonin there in order to make ourselves feel good. We don't have any other way to do it directly, and because feelings, actions, talking, and thinking are our four major dynamic ego functions, we can deal with the top three, the actions, talking, and thinking, but it's very hard to deal directly with the feelings. Feelings are hard to reach.
So basically then, at least so far, what you're pointing out is that an individual who has experienced a trauma, at some point, as we mentioned earlier in the show, needs to regain control.
That's correct.
Over the situation. One way would be to help the individual recall the event at whatever point they're ready to do that, and couple relaxation rather than upsetment with the event. In general, though, it sounds like you're in addition to that, you're taking the individual patient's particular symptoms, whether they are anxiety symptoms, depression symptoms, whatever they may be, and attacking those symptoms in whichever way the therapist feels is best, whether it's medication, psychotherapy, but you're taking each individual separately. There's no sense that, okay, you have a PTSD, you've been traumatized, this is the treatment for you. It has to really be individualized, right?
It has to be tailor-made for each person. If they're presenting a depression, there's a host of treatments available. There are different names given to them, cognitive behavioral. Sometimes we use biofeedback, where people actually begin to control the rate of perspiration, control their breathing, control their the ability to the blood flow within the body. Their muscle tension is controlled. Biofeedback's a very useful tool.
And that counteracts the effects of stress on the body.
Exactly. Furthermore, when we get into the relationships in the family, we try to analyze with the patient and with husband, wife, or children, the levels of cooperation, compatibility, emotional support, and intimacy that exist within the family structure. Those are very important dynamics. And people sometimes, since we don't get any diplomas or degrees to be married or to be parents, we have to re-educate people, including ourselves, since we're people who weren't trained either in our early lives, to increase levels of cooperation, compatibility, emotional support, and intimacy. When we're able to get those at a higher level, people can begin to function in a much more comfortable way with one another without letting the traumas interfere with their daily lives. The measures that I use with patients is I use a love assessment scale that I've created called it incorporates 5 ingredients: acceptance, how much a person accepts his or her mate; concern, how much concern they have, we try to measure that; understanding, how well they understand their mate; respect, how much respect they have for them; and trust.
Now, is this designed to simply help the patient, or the identified patient, as we used to say in a family, the individual that has experienced the initial trauma, or is it designed to help the entire family, who you mentioned earlier are all affected by the trauma?
The entire family is affected. Normally people with PTSD, the family has now learned to distrust them because they're very estranged from them. They've learned to disrespect them because the person is no longer functioning at the level they were accustomed to. They don't understand the problem, and it's very important and critical to explain to the family when someone has been traumatized as to what actually happened and what's going to happen within the family structure. So
education, basically.
Education is extremely important. They may be very concerned about the person, and that's why they're there in therapy. That's why they're bringing them in, or they're coming in with them. And acceptance normally has gone down quite a bit because it's very hard to accept someone you don't understand. And so that becomes very difficult. The biggest problem to try to avoid is to get one of the partners, whoever is not suffering with the PTSD or with the subsequent problems, to not unconsciously and repetitively and compulsively and irrationally and self-destructively victimize themselves. And this can become a repetitive process because it's very easy to be victimized by someone who is suffering in a way that you don't understand.
Could you talk more about that just a little?
Well, when you can't deal with someone who is suffering that way and you can't express your anger directly, it's the only easy way to get revenge is to feel victimized. Like, if I wouldn't feel so bad if you weren't doing this, and therefore the revenge becomes feeling miserable, and so the other person feels miserable, and then the other person is misunderstood, and both people are further estranged, and the whole family starts falling apart. And this is the unfortunate consequence of these kind of disorders.
It's fascinating as we talk about it, because really it would seem that there are almost three stages that a family might go through, the individual and the family. First would be the actual event that triggers the trauma in the individual.
Right.
The next would be as that person develops and lives and experiences, and that event becomes sort of incorporated into their personality structure, certain symptoms occur. That would be the second stage. And then the third stage would be as the family adapts to the symptoms, the family develops difficulties. It may not necessarily develop symptoms of post-traumatic stress disorder, but there's family dysfunction. So it's really a very, I think your title of Silent Killer is very apt.
Yeah, so that's how it destroys and kills the family. Family structures are definitely destroyed by this disorder, and people do not understand really what is going on. And fortunately, some physicians are better trained now, if most physicians are, and are able to make referrals to psychologists to get help for these problems. But it's not something that's easily identifiable because it's not a clear physical sign. It's a psychological sign, and something that requires someone with psychological expertise to be able to investigate it better in a more effective way.
I could certainly see how many individuals with PTSD symptoms would be missed if they might go to a physician who would focus on the specific symptom, whether it's headache or fatigue or insomnia or agitation, anxiety, whatever it might be. Insomnia is one of the, I think, one of the most common side effects of symptoms that is often treated by the family physician, but the underlying cause is completely missed.
That's
and
correct.
It's very sad.
Yes. It's clearly a disorder that is treated symptomatically, and generally it's a residual of many of the PTSDs, and which go into chronic sleep disorders.
Mm-hmm.
We have many articles that support this kind of finding. At any rate, the post-trauma trauma takes place in many ways. I remember one patient, a rather interesting patient, a very kind, pleasant, religious woman, developed, went through a trauma. She went and seduced unfortunately, a couple of priests, which she felt extraordinarily guilty about, and at least that's what she claims. And she claims that she had these relationships. And what happened was she developed what we call an obsessive-compulsive disorder from this trauma. What she did was she would feel that everything she touched was contaminated. And so every year she had to get rid of her apartment and buy a new apartment. Her husband was getting a little upset with all the money she was spending. She had to buy all new furniture every year. She would throw it all out or give it away. She had to get rid of all her wardrobe because that was contaminated. She would wash all the doorknobs when she'd come into my office. And in those days, she used to pay in cash, and she used to wash the money and press it and make sure it was put in a very clean envelope so that this way it wasn't contaminated.
Well, you know what's funny, that frequently individuals who hear this are somewhat amused. You know, boy, that's what a wacky woman. And I guess to some extent some of her behaviors can be considered amusing, but not to her.
No, it was not.
Her life must have been torture.
Her life was absolute torture, and what made it worse is she had a very responsible position with a very large company, and back in those days she destroyed a bond, a bearer's bond, which is like cash. She burned it because she felt it was contaminated, and it was worth $800,000.
Oh my!
So that was so you can see where an illness can really deplete your resources.
Talk about post-traumatic stress disorder. Whoever bond that was, certainly.
Well, the company will remain unnamed.
Good.
But the more serious PTSDs become psychotic, and these are people who you may have seen, people who become what we call schizophrenic, totally withdrawn, or people who become manic depressive and start flying high, drive recklessly, spend money extravagantly, go on buying and sexual sprees, feel on top of the world, are super energetic. These are all kinds of wild manifestations to basically counteract the effects of whatever a trauma may have done to them.
There's so many elements to any kind of therapy, specifically to trying to treat people with such complex disorders. I know with many of my patients, one of the primary virtues that both therapist and patient must develop is patience.
Yes, a lot of patience.
These are tough things to overcome.
They're very tough to overcome, and many people want a quick fix, and the medications don't even offer quick fixes. A normal clinical depression is going to last from anywhere from 6 months to a year, and that's a minimum time. We would like to be able to eliminate them overnight, but unfortunately, like many diseases, such as physical diseases like cancer, you can't eliminate that overnight unless you catch it very early. Now, if we could catch these diseases at an earlier level, I think we could do a great deal more to help people with them.
Would you agree that therapists use their own experiences in helping their patients?
Well, I think that if therapists have gone through some negative experiences, they usually can empathize more with the patient if they are they have a more feeling and understanding of what's actually taking place.
It's crucial, I think, that therapists are able to utilize their own experiences. Not that the experience has to be similar, and I think many times patients don't understand that therapists have had events in their lives that are not corresponding perhaps to theirs, but a therapist is able to evoke what we call empathy for their pain, because he or she, as a human being who happens to be a therapist, also has experienced pain. And frequently patients will say, well, this hasn't happened to you. And you say, yes, that's correct. That hasn't happened to me, but those feelings have happened to me.
Absolutely. We're human as well as the patient, and we're patients ourselves when we're in trouble. So We're not invulnerable to any of the diseases or disorders that we're talking about today.
Not all post-traumatic stress disorder has to be treated, obviously, in family therapy, correct?
Oh, absolutely not. However, it's a good idea for the family to be involved, because this family support can be instrumental in helping. Now, in more extreme cases, when it really deteriorates, as I've done this year, for example, I sent 4 people for ECT, electroconvulsive shock therapy. Their depression and PTSD was so severe that they could not recover, and they needed some relief. None of the medications were working, none of the therapies were working, but ECT did provide them with some relief. ECT was developed back in 1938 by 2 Italian fellows by the name of Cerletti and Bini, and it was it's supposed to bring the brain chemistry back into a stable state. And normally with 12 sessions, it can do a very fine job, and we have very positive results. People don't even know they're going through it. They put on something like Valium, and they just sleep right through it. It's an instantaneous type of treatment, and only good in cases where the disorder is intractable.
Has become so debilitating and intractable to any kind of treatment, certainly.
Exactly. And then the most extreme is what we call lobotomies, which we call suborbital undercuttings. And I had 3 patients over my 40 years go for those, but these are people who desperately wanted to go, and we needed 7 other opinions before the neurosurgeon would operate. They got a great deal of relief. They didn't lose any IQ points. I tested them before and after. And that's a very extreme treatment.
Extremely extreme, yes.
Right.
The goal then really with anyone, but specifically somebody who has experienced a trauma in their lives, and we've said this many times, is regaining control over the event.
Regaining control.
So that the event no longer controls you, but the event is now synthesized into your overall personality structure, so it becomes one part of you. I think that another aspect to trauma as a silent killer is individuals who become aware of their trauma and get stuck in it. You know, you say, well, how are you? I'm fine. You know what happened to me? And they immediately go into the trauma. It's as if even though the event is over, they're still stuck there. And it's good that they're aware of it, but the ultimate goal is to move on, to take the air out of the balloon so that it can just become an event that occurred or events that occurred in your life rather than the defining moment in your life. Would you agree?
Absolutely. Bill, I have to say that your insight in these matters is quite astute.
We have to have you back very soon. I want to thank you very much for taking the time to join us today. Please come back.
My pleasure.
Please come back. This was a fascinating topic, and I think one that affects so many people, and certainly something that we'd want to talk more about in the future. Next week, our topic is going to be understanding individuals who are intellectually challenged. Very frequently, people who have intellectual impairments are segregated, and there's tremendous misunderstanding about this particular group of people. Our guest is going to be Dr. Joseph Fisher, who's the chief psychologist at the Hunterdon Developmental Center. And we're going to be talking about understanding these individuals, some of the family dynamics they experience, and probably some information that certainly shocked me and may shock and surprise some of our listeners. So again, thanks for joining us, and we'll see you next week.